Hello, everyone, and thank you for joining us on this wet fall day. Please feel welcome to cozy up with a cup of coffee, a cup of tea, or your favorite pumpkin spice latte for our time together. Before we begin, we would like to respectfully acknowledge that Arthritis Research Canada's headquarters are located on the stolen traditional territories of the Coast Salish peoples, including the Musqueam, the Squamish, and Tsleil-Waututh nations, and we express our deep gratitude to the keepers of these lands and waters. I'm thrilled to be your moderator for today's webinar, and I'm excited to learn from our experts, Dr. Raheem Kherani and Dr. Carrie Yee. If you're joining us for the first time, this webinar is part of the Arthritis Research Education Series, which was created by our Patient Advisory Board to share research undertaken at Arthritis Research Canada. Doctors Kherani and Yee will give a short presentation and then we'll answer your questions. Please click on the Q&A icon that you see in the lower right-hand corner of your screen to type in your questions. We also invite you to stay on at the end. We're going to share a 6-minute video that was prepared for this episode. It's my pleasure to introduce Doctors Kherani and Yee. Dr. Kherani is a clinical associate professor at the University of British Columbia and a clinician investigator here at Arthritis Research Canada. He currently practices as a rheumatologist at West Coast Rheumatology Associates and the GF Strong Rehabilitation Centre, as well as Vancouver General Hospital. He's also the division head of rheumatology in the Department of Medicine at Richmond Hospital. He completed his Bachelor of Science in Pharmacy and his medical degree at the University of Alberta, as well as a Master's of Health Professional Education at Maastricht University in the Netherlands. He also assisted in the development of the Osteoporosis and Sjogren's disease initiatives in British Columbia, including the development of and advocacy for the fracture liaison services. Dr. Yee is a clinician scientist and an associate professor of medicine at the University of Alberta, where her research focuses on the intersections or connections of bone, cancer, and artificial intelligence. In April 2025, she was appointed as a research scientist at Arthritis Research Canada. She practices rheumatology in Edmonton, Alberta, and is the medical director of the Northern Alberta Osteoporosis Program, which offers multidisciplinary care and education for patients, training for residents, and comprehensive clinical data for researchers. So without further ado, I'm going to turn over to Doctors Kherani and Yee.
Thanks very much, Alison. It's a pleasure for us to be here, and we're looking forward to not only presenting and helping with learning more about osteoporosis and bone health, but we're also looking to learn from you with questions after the formal part of the presentation. Next slide.
So we've done this land acknowledgement.
Yep.
So I'm going to do mine now because I am here at the University of Alberta, and our buildings, labs, and research stations are primarily located on the territory of the Nehiyaw, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe, lands that are now known as part of Treaties 6, 7, and 8, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So, thank you all for joining us. We hope to cover quite a bit on bone health and osteoporosis over the next half an hour or so. So this is the outline, and Dr. Kherani and I are going to kind of switch off between these topics. We're going to start by talking about osteoporosis and who it affects. Then we're going to go through risk factors for developing osteoporosis. We'll talk a bit about bone density and how we determine fracture risk. We'll talk about osteoporosis prevention and management, focusing on diet and exercise with just a little overview of the medications that we use. And then we'll each share a little bit about our research relating to bone health. I will just say we don't spend a lot of time on medications just because there's so much to cover. And also, we're very happy to answer questions, but anything related to individual health, your own medical health, and giving any sort of medical advice, we're going to leave alone during this webinar, and we'll encourage you to talk to your own healthcare providers about that. Okay, so I'm going to talk about osteoporosis and who it affects. So first of all, I think a lot of us think about bone as just sort of this inert, hard thing, but it's actually living tissue. It's constantly renewing and repairing itself, much like your skin, right? Dead skin sloughs off, and then you get new skin, and that's what keeps your skin healthy. So our bones are composed of bone-building cells, and we call those osteoblasts. We also have bone-removing cells called osteoclasts. And then we have collagen, proteins, and minerals like calcium that makes up the rest of the bone. So what is osteoporosis? So translated from Latin, osteo means bone, porosis means pore, and osis means condition of. So this is a condition of porous bone. And with osteoporosis, the bones become thinner, they become more porous, and they become more fragile, and thus increasing the risk of breaking these bones, otherwise known as fracturing or fractures. So you can see in this picture on the left-hand side, that's normal bone. And as you move towards osteoporosis, which is a spectrum, you start seeing that those holes get bigger and the little bridges around the holes, the actual bone matrix actually starts to thin out. And so you can see how the picture on the right-hand side, that just doesn't look as stable or strong. So we can diagnose osteoporosis in two main ways. One is if you've suffered a fragility fracture, so breaking a bone under circumstances we normally wouldn't expect you to break a bone, so low trauma circumstances. Regardless of what your bone density is, that is considered osteoporosis. Now, before you break a bone, we can also diagnose osteoporosis based on your bone density scan results, and we'll talk more about those in another section. And the result of these are fractures, and there's lots of different osteoporotic fractures you can get, but the two main ones that cause a lot of pain and reduction in your quality of life are hip fractures and spine fractures. So you can see here at the top, that's the picture of a hip fracture, and the fracture line with the blue arrow, that's where most hip fractures occur, sort of at that small spot of the femur bone. And then spine fractures look a little different. Those are considered compression fractures. So you can see in the middle picture here where there's the red arrow, that is one of the vertebral bodies that's compressed. And that can cause a lot of pain. And with accumulation of more of these compression fractures in the spine, you can develop a sort of hunched posture, a reduction in your height, and that can also affect your quality of life. So who gets osteoporosis? Well, women get osteoporosis. Women in general have smaller, thinner bones than men. And after osteoporosis, when you get that reduction in estrogen, in the first 5 to 7 years, you can actually lose up to 20% of your bone density. And then after age 50, approximately 1 in 2 women will actually break a bone due to osteoporosis. So this is very common. However, it's important to remember that men also get osteoporosis. Even though men start off with larger, stronger bones, with aging and declining testosterone levels, men can also develop low bone density and develop osteoporotic fractures. And after age 50, approximately 1 in 4 men will break a bone due to osteoporosis. So still very common in men too. All right, Dr. Kherani, over to you.
That was a very good overview of the osteoporosis and who it affects. And now we'll get a chance to talk about osteoporosis risk factors. The next slide. There are some risk factors that we don't have control over. Some of these are genetic factors, like as we age, there is more risk. If there is a family history of hip fractures in particular, earlier menopause when periods stop at ages younger than 45, and also if there is a low bone mineral density. And we'll talk more about that in a bit. Next slide. There are also medical conditions that can also increase our risk. And so some of those medical conditions are listed here, like autoimmune conditions, conditions that can affect the bowel and absorption, conditions that can affect the hormones that affect men and women, as well as chronic diseases that affect the liver and the kidney. Also, there are conditions that affect the parathyroid or the salts in our blood and the thyroid function, but even other situations where we're just at more risk of falls, or if we have an unexplained or a fragility fracture, as Dr. Yi was talking about, having had a fragility fracture already puts us at more risk of a future fracture. Next slide. Medications, there are certain ones that can also increase our risk. At the top of that list, and most important, are corticosteroids. One of the common ones that we use in Canada that is an oral medication is prednisone. And if it is used at a dose of 5 milligrams or more for over 3 months in the past year, that increases our risk. There are other medicines that may increase risk as well, including medications for seizure, some thyroid medications, proton pump inhibitors, as well as medications that can lower estrogen or testosterone. Some of these we use in cancer, in some forms of cancer treatment, and so these can be of concern and may put us at more risk. Next slide. The lifestyle factors that we can control are important. Why are they important? Because we can do something about them. And by being able to do something and impact these particular factors, we can make a difference in our current risk and perhaps our future risk of osteoporosis and bone fractures. Little or no exercise, cigarette smoking, increased quantities of alcohol, even more than 3 cups of caffeine a day are important risk factors that we can change. If we are not taking enough calcium or vitamin D through supplementation or even through our diet, then that can be another way that we can impact osteoporosis risk. Next, I'll pass it back to you.
All right, thank you. So we've been talking about bone density, and how do we determine bone density? Well, we have to do a test for it. And who should be getting these tests? In Canada, anyone over the age of 70 should be screened with a bone density test, regardless of any other risk factors. So those are the official guidelines from Osteoporosis Canada. However, if you're under 70 years of age, and you have other risk factors, then you should also get a bone density scan earlier. So for example, if you've broken a bone, that's considered atraumatic or low trauma. If you have been exposed to steroids, such as prednisone, dexamethasone, there are others as well. If you've had lots of falls, if one of your parents has broken a hip, if you have certain medical conditions that Dr. Kherani has touched on, if you smoke or if you drink excessive alcohol, those are reasons why you might need a sooner bone density scan. And then the other reason we get bone density scans are to monitor the effectiveness of our treatment. So you'll get a baseline and you might get a follow-up to see if our drugs are working. So this is a DEXA scanner. DEXA scans are, it stands for dual energy X-ray absorptiometry. That's the main way we get bone mineral density. And it takes a very low radiation X-ray of your lumbar spine, which is your lower spine segment, as well as your non-dominant hip. So if you're right-handed, we take an X-ray of your left hip. And this measures the calcium content of your bone. It is painless unless you have trouble laying flat. And it's quick. It takes less than 15 minutes to do the scan, and there's very little radiation. In fact, it's less radiation than a chest X-ray, and it's similar to the amount of radiation you would be exposed to flying from Vancouver to Toronto. So here are some pictures of DEXA scan images. The first one is of the lumbar spine. The middle one is of the hip. And if you have a reason we can't scan the hip or the spine, so for example, if you've had metal put in there for different reasons, then we would also scan the forearm, your non-dominant forearm. So that's what the last picture there is of. And from those images, we get a bone mineral density. So that's the BMD, and that's measured as grams per centimeter squared. But we generally look at something called the T-score, and you'll see there the last column has numbers like -3.2, -1.5. And you'll remember maybe from a few minutes ago that I said we can diagnose osteoporosis based on your bone density alone, and that criteria is a T-score of less than -2.5. So without going on about statistics, just quickly, T-scores compare your bone density to a reference range. And the reference range here are healthy 30-year-old female bone density. So it's kind of interesting, even men who get bone mineral density scans are compared to the same reference cohort, and everywhere around the world gets compared to the same, so that we're all speaking the same language when we're talking about bone densities. And for each -1 in the T-score is another standard deviation below the average. And that's not the most important thing to understand. What is important to understand is when you have a T-score that's less than -2.5, which is the cutoff for diagnosing osteoporosis, your bone density is in the smallest 1 percentile or the lowest 1 percentile of bone density when comparing to this reference group. So we're getting into pretty low bone density here. And then how do we use that to predict your future fracture risk? So bone density alone does not solely predict your risk of breaking a bone. We have to think about other factors as well. So the most commonly used fracture risk prediction tool is something called FRAX. It's used all around the world, but there's a unique tool that's been built for every country based on that country's fracture risk across the country. So we have one built in Canada, and what we do is we enter in information like your age, your sex, your weight, your height, prior fracture, if your parents fractured a hip, do you smoke, have you been exposed to steroids, do you have rheumatoid arthritis or other conditions that predispose you to fractures, do you drink excessive alcohol, and then we also put in the bone mineral density results. And then you click calculate, and what we get is your risk of breaking a bone in the next 10 years. And when that number is greater than 20%, we consider you high risk. When it's less than 10%, we consider you low risk, and in between is moderate risk. All right, Dr. Kherani.
Ooh, I guess what we should have said to people was to fasten their seatbelts, because this is a lot of information that we're throwing at you. But we wanted to be able to arm you with not only what osteoporosis is, what are the risk factors, and how do we determine that diagnosis, but what can you do to prevent it and also to help with management. And so we'll give you some information about this, and we really want you to be able to talk to your healthcare providers to get even more information that will be customized for you. So next slide. Osteoporosis prevention is something that we can start when we're young. In fact, in childhood, it's important because we're able to improve our nutrition and physical activity from a very young age. And as you can see on this graph that shows age and bone mass, with a graph that goes up as we get older and markedly goes up during puberty, and then continues to go up in the 20s and 30s, where they reach peak bone mass. And then, particularly after the age of 50, there is a more rapid decline, and we lose that bone mass after menopause or for men after the age of 50. And so these are important things, and so we can minimize the harm of losing or optimizing our bone mass and prevent things by optimizing our medical conditions, medications, and also limiting smoking and alcohol, which can be really great steps in working with our healthcare providers to be able to help that for us. Next slide. Now we're going to dig into a little bit about management of osteoporosis, particularly things that you can do for yourself, as well as things that you can consult with others to help you on. So next slide. These categories, nutrition, exercise, daily activities, connecting with others in your networks, as well as medications, can all make an impact on improving your bone health. And we'll talk about more details on the next few slides. Next slide. The healthy diet is going to be really important. What you see here is a representation from Canada's Food Guide on healthy eating. And in there, you can see the proportions of foods that we should be eating. Also, it's important that we include 3 meals a day with protein, and that those proteins also are represented by dairy products like you see on the plate. And you can include water, as it says, but also replace that with milk for helping your bone health. Next slide. Calcium can be really important, and if we can include that in our diet, we've got some examples here of looking at the nutrition facts label on a food label, looking at different sources of products where you can get calcium through your diet, and then a table here that is with the age categories of 1,000 milligrams a day for those less than 50, and over 50, 1,200 milligrams a day, and splitting that up will be ideal. Next slide. Vitamin D, we call the sunshine vitamin. Unfortunately, in Canada, we just aren't at the right level in the world to be able to get as much vitamin D made from the sunshine that we get. And so all year around, Canadians are recommended to take vitamin D as a supplement. Why, you might ask? Well, because vitamin D helps the body signal and sort the calcium into the right places and making sure that we get some in our bones. Because it's recommended for everyone, we might ask, well, how much? And so we've got a table here on the slide that talks about how those that are over 50 will need 1,000 units or more, as well as those that are under 50 with osteoporosis, but those that are under 50 without osteoporosis may be able to do with less vitamin D. Next slide. Physical activity, something that hopefully many of us are doing on most days of the week. Why is that important? Because a number of different types of activities that you see on this slide are outlined so that they can help us with being able to do some activity as often as we're able to and feel comfortable with, to be able to get aerobic physical activity, so about 2.5 hours or 150 minutes, particularly like it shows in the slide, walking would be a great weight-bearing kind of activity. Muscle and bone strengthening activities, about 2 days or more per week, and then other physical activities that really enhance our balance and prevent falls. And we'll give you some examples in the next couple of slides of those, but also practicing spine sparing strategies, really to help our posture. And as I say that, I remind myself to sit up in my chair. Next slide. Nordic pole walking. This is a great way that we can engage with exercise. Why? Because it gives us a bit more stability with walking and holding those walking poles, particularly when we're doing this outside. It really promotes that upright posture that Dr. Yi was showing that we can see change in some people over time as they develop and progress with their osteoporosis. It really uses the upper body in addition to the lower body. And so there are different ways of getting information about this, and we've given an example of one. Next slide. So on the next couple of slides, just some guidance for movement, for helping spare the spine in terms of being able to sit up from a chair or lifting things. So sitting up from a chair, called the hip hinge, if you place your hands into the crease of your hips as it shows in the first picture, and then starting to stand and putting pressure, keeping your back up and extended, and then spreading that load through your hips and legs as it shows in the last picture. And so this can be a strategy in which to be able to help with protecting your back. Next slide. And other ways of protecting our spine can be when we're lifting things and then putting it in another place, that we turn our whole body by rotating or turning our feet and then using our hips rather than our spine as a way to step and turn. And that will really help us with protecting, again, our back. Next slide. Medications. I know already there are some questions around medications, and this is really important, but often it's really individualized in terms of the care and the medical conditions and the experience that you've had with other medications or other medical conditions that are a part of your history. And that's why seeing your care provider about medications can be really helpful and important to be able to make the next steps in deciding if and when medications are appropriate for you and what medications. But to help you with that, we'll just review the next slide so that we can actually talk about a way of you understanding the different kinds of medications, groups of medications that we use to treat osteoporosis. And you see them here. And we referred to them earlier as cells that eat up the bone, or osteoclasts, and so they resorb bones. So there are medicines that are called anti-resorbers, and the other class affect osteoblasts, the cells that build bone, and so those medicines are called bone formers. And so underneath the anti-resorbers, that first category, are bisphosphonates, denosumab, estrogen therapy, and selective estrogen receptor modulators, or SERMs. And then under the bone formers that stimulate osteoblasts, there's teriparatide and romosozumab. And so these medicines work in different ways and can be individualized to help. And in some individuals, we will use just anti-resorbers, and in some we might use bone formers and then follow those with anti-resorbers. Next slide. I'll pass it back to you, Dr. Yi.
Thank you, Dr. Kherani. That was a lot to cover. And I mean, I wish we could spend half an hour to an hour on each of those topics in terms of diet, exercise, spine sparing, fall prevention, medications. But that was a great overview. So we're going to end off with just a little bit about some of the research that's happening within Arthritis Research Canada, the projects that Dr. Kherani and I have each been working on. So I do a lot of population-based research or epidemiology research using big data from different provinces. And a lot of my work is around fracture risk prediction. So I just wanted to share some of the findings that our group has come up with in the last couple of years. So one of our studies showed that even remote fractures, so fractures that occurred more than 10 years ago, still increase your current and future fracture risk. So that broken wrist from 15 years ago actually still matters, and we should still consider it when we're deciding if we should treat you now. We also did a study where we looked at fractures that occurred in early adulthood. I think a lot of people consider osteoporotic fractures only when they occur in the elderly. But what we found was that even fractures occurring in your 20s significantly increase your risk of fractures when you're older, when you're in your 50s, 60s, 70s, and 80s. So again, we should not be ignoring fractures that occur even in early adulthood. In childhood, it's slightly different. There's a lot of growing bones and sort of different risk factors for fractures at that point. We also found that vertebral fractures on their own are very painful and certainly can affect your life. But what we also found is that having vertebral compression fractures actually speed up the development of osteoarthritis or degenerative arthritis in the spine. So even more reason to try and prevent these fractures. And that's why Dr. Kherani spent some time talking about spine sparing strategies, because that's something we can do actively every day to try and prevent vertebral compression fractures. Another area that our group has worked a lot on is looking at immunotherapy for cancer. This is a new group of medications that's really taken the cancer world by storm. And because they're new, we don't quite understand all of the long-term implications of these drugs. And what we've done is shown through lots of different studies that maybe these drugs actually increase the risk of osteoporosis and fractures. So lots of ongoing work in that area. We've also done some validation work to show that FRAX, that fracture risk prediction tool, is accurate in people with cancer. It was validated on the general population, but we show that it's actually quite accurate in people with cancer. And then lastly, we're doing quite a bit of work on using FRAX to predict outcomes other than fracture. So we have found that it predicts heart attacks and stroke. And I think that's important because a family doctor has to consider risks of so many different outcomes. And that's a lot of work to put in these calculators for every single outcome. So if we can develop one single calculator that can help predict lots of different outcomes, that would make fracture or risk prediction a lot easier for physicians. So that's some of the research I've been working on. I'll pass it over to Dr. Kherani to talk about his great work.
Thanks, Dr. Yee. I've been trying to work over the last number of years on education, advocacy, and access, and today's webinar is an example of us being able to educate the public generally, care providers, and even specialists in osteoporosis, and being able to develop tools and work on strategies has been really interesting. And with the support of a variety of funding agencies, we've been able to do both research and implement programs in osteoporosis to help with a fracture liaison service. Can you imagine when you go to the hospital and you have a heart attack, you would want to leave the hospital with some sort of treatment that would prevent the next heart attack. And as we've told you today, that when you have a fracture, you're at higher risk of another fracture. So if you end up in the hospital getting help to treat a fracture, it will be important to be able to get advice and guidance on how to prevent future fractures. And that's this example of a fracture liaison service program. And we've been able to work with different hospitals and with a large team, along with collaborating with provincial governments to be able to help with being able to look at implementing fracture liaison service programs into various centers. In addition, the vertebral compression fractures that Dr. Yee spoke about, we've been able to look at, is there an intervention that we can do? And we've just finished recruiting for a vertebral fracture exercise study. So those patients that enrolled have had vertebral fractures and they're getting exercise education to be able to help and speed their recovery. And so that study will hopefully enable us to then do future studies that will be larger and hopefully recruit more patients. So stay tuned. We continue to look at ways to be able to impact the provincial delivery of osteoporosis care, and in particular, access. And so with other colleagues in the province, as well as at Arthritis Research Canada, we've been looking at how we can look at that implementation and be able to improve it, not only for the general community, but also for Indigenous communities in Northern British Columbia. And so we're continuing to work on efforts building on previous surveys that we've done. I think we're getting close to the end, Dr. Yee, so that we can address questions that individuals participating have specifically for us. I'll pass it to Allison.
Those are all our slides.
There we go.
Thank you for that excellent presentation. So clear and compelling. I'm grateful for all the information that you have both shared with us. And, I'm definitely going to watch the recording. I know that there's a couple of questions in the chat, in the question and answer part of the Zoom, where people are asking, those are great slides, but can I get that information again? I would love to take another look at how much calcium to take again, or how much vitamin D to take again. I'm happy to say that the recording of the presentation will be on the website by next week. I'm definitely going to watch it again so I can prepare questions for my appointment with my rheumatologist next month after my bone density scan, because there was great information there. I'm happy to now open it up for questions. Remember that you can enter your own questions, but you can also upvote questions that people have already put in the Q&A box. So there's a little thumbs up icon beside the question that you can say, yeah, I'd also like to hear the answer to that question. We're going to do our best to address as many questions as possible, but there is a possibility that we could not be able to address all of them, or some of them that in particular, as Dr. Yee has said, are more relevant to your own particular medical situation. It's not possible, it's not good practice to answer medical questions that are specific to your given situation in a situation like a webinar where your own health professional has your records and has that information available to guide you specifically for your own individual situation. So let's start with some of the questions. One of the questions is, okay, Dr. Yee, you shared that so many people in Canada have osteoporosis, and that the guidelines are to do the bone density scan for the first time for people that don't have a higher risk at age 70. Why is that the case? Should it be starting earlier in order to identify them earlier?
That's a great question, and it is a balance of resources, but also picking up low bone density without other risk factors likely won't lead to treatment or recommendation of osteoporosis medications. And so that's why we try to save doing these scans for people most likely to need treatment if there is low bone density detected. So if you're under 70 and you have other risk factors, then having a low bone density will likely result in a recommendation of treatment. But without those risk factors, it's unlikely. And so that's why the current guidelines are to recommend at a population level, everybody over 70.
Thank you. Dr. Kherani, did you want to add anything to that?
No, that's really helpful information and hopefully helps characterize it for why. It's the end effect of the test in terms of recommending treatment or not that really is limited when individuals either are younger or if they're younger in particular, without risk factors.
Sounds like a lot of thought has gone into those recommendations. Thank you. There's a question about a particular product here called Evenity, Evenity. Would either of you like to comment on that?
Yeah, so the Evenity, the generic name for that medication is romosozumab. And so it's one of the bone former medications that we had in the slide that talked about the different kinds of medications. And it's a medication that in the right setting and in right circumstance can help an individual with building bone. And then as we talked about that after using the bone builders, that we will often then use anti-resorbers, like the various ones, the bisphosphonates, and the other ones that we talked about, to be able to help with continuing to help the individual's bone density using medications.
Thank you. A lot of people have upvoted. Oh, sorry, Dr. E, I noticed that you unmuted. Did you want to add anything to that?
Well, I did take a peek at the Q&A and I saw some questions specifically about cardiovascular risk and also sequential therapy. So I thought maybe I would just address it if that's
Yes,
okay now
please.
as we're talking about romosozumab. So I always have a pretty detailed conversation with my patients about romosozumab or Evenity if we're going to consider using it. And that's because that cardiovascular risk piece is a little bit hard to understand. So in the studies where romosozumab was compared to another drug, so it was alendronate, it was in that study where they saw that slight increased risk of heart attack and stroke. In the very massive study where romosozumab was compared to placebo, so no drug, there was actually no increased risk. So it's a bit hard for us in the bone community to understand if it's actually the romosozumab that increases the risk of cardiovascular disease or if the comparator drug, alendronate, may actually reduce the risk. So I always take the time to explain that because it's not very clear right now, based on the evidence we have, if it truly does increase your cardiovascular risk on its own. And then Dr. Kherani already talked about the sequential therapy a little bit, but just to make it very crystal clear, anytime you use an anabolic therapy, so teriparatide we usually use for 18 months to 24 months, romosozumab is for 12 months, you always need to follow that up with an anti-resorptive agent, so either the bisphosphonates or denosumab, because if you don't, within about a year, you'll actually lose all the gains that you developed from using the anabolic agent. So it is really important that you always follow that up. So I hope that just clarifies some of the questions in the chat.
Yeah, thank you for looking ahead at some of those questions. And I think that's such an important context because as patients, we can do a Google search and find out information that it is associated, that there's evidence to say it was associated with cardiovascular risk, but we didn't know that context of what was included in that study versus other studies and how that has to be interpreted by the healthcare professional to our own particular situation. So thank you. Okay, there are lots of people that are interested about is there any influence of having a joint replacement? Is there an association with that and osteoporosis? Would either of you like to comment on that?
I could take a stab at that. So getting a joint replacement does not increase your risk of osteoporosis on its own. Now, if you get a joint replacement and you're immobilized for a long time and you're deconditioned, that might put you at risk of some harm to your bones and reducing your bone density. But on its own, no, it does not cause osteoporosis.
Thank you. There's also some questions about PPIs and how so proton pump inhibitors. So for people who are taking proton pump inhibitors, and what did the literature say before and what does it say now? Does that increase risk of osteoporosis?
That's an important one because when we are taking the proton pump inhibitors, they may limit our absorption of these important factors that we take in, like calcium, because of the changes in the acidity of our stomach, and that's one of the ways that that's the main way that the proton pump inhibitors work. And so, being able to use the proton pump inhibitors when they're appropriate and being able to limit their use when it's not needed, and having that discussion with your healthcare provider can be really important in being able to make those decisions about that kind of medicine moving forward.
Thank you. Okay, there's some questions, and I guess this is a struggle when words sound so similar. Is there a relationship between osteoporosis and osteoarthritis? What are those two terms and how are they related?
I could take a stab at this one. Yeah, this Our patients get these two mixed up all the time, which I totally understand with the osteo in the front, but they're essentially not related. One is pertaining to joint disease, so that's the osteoarthritis, and one is talking about the actual density of the bone, so that's the osteoporosis. Now, if you really want to go deep into this topic, there is some relationship. There's some studies that show maybe if you have osteoarthritis, it might actually be slightly protective of osteoporosis. But then there's actually studies that show maybe those are actually risk factors for each other. So I would say the easy answer is to just separate these two diseases in your brain, and we don't generally consider them risk factors for each other.
Thank you. As you shared in that earlier slide about defining osteoporosis, osteo means bone, so it just means they're two bone related things. Thank you. I noticed there's also 13 votes upvoting for people asking about the relationship with hormone replacement therapy and osteoporosis. Do either of you wish to speak to that?
Hormone replacement therapy had been an important piece in the armamentarium for managing and helping with osteoporosis. It's been limited more because of concerns about other risks that come with it, in addition to the benefit that it may help with helping symptoms related to menopause, but in addition to building bone. But because of concerns with the with cardiovascular risk, there may be concerns in terms of taking them for longer and longer periods of time, but they are included as part of that list when we were including things that will help with reducing resorption from bone as a part of those items for consideration. And so it still fits in, but it's something that we would discuss with our healthcare providers in terms of whether it's appropriate and appropriate in the situation that you're in.
Thank you. What about B12 and folic acid? There's a couple of questions related to that. Would either of you like to speak to that?
I mean, I think with B12 and folic acid, they're really essential vitamins for general health. But as long as you're getting the sort of general Health Canada recommendations, there's nothing extra you need to do for osteoporosis. So B12 deficiency and folic acid deficiency, unless you kind of go through convoluted pathways, generally doesn't directly impact your bone health.
There's also a question here noting on your slides and that you spoke to the risk factors. One of the risk factors is having rheumatoid arthritis. Do other forms of inflammatory arthritis or autoimmune arthritis affect risk, increase risk?
Certainly they can. The rheumatoid arthritis is listed in the fracture risk assessment tool as it's the best studied. But there have been studies in other inflammatory conditions where they may be increased risk of osteoporosis. The one that's again best studied is rheumatoid arthritis, and that's why it's listed. Excellent question.
I'm just scanning through the 52 questions that are in the Q&A to see if there's any that I missed. As you're looking as well, Dr. Kherani and Dr. Yee, are there any that I have missed that you would like to address?
I do see that the question about vitamin K has been upvoted quite a bit, and I'm happy to answer that.
Yes,
We get
please.
asked about vitamin K a lot, and actually, we did a pretty thorough literature review of this topic recently. And the bottom line is, it is very easy to get adequate vitamin K from your diet. So in most people, just eating your regular healthy diet is enough vitamin K. Now, where there's been particular studies of additional vitamin K supplementation to try and reduce fractures or improve bone density, The vast majority of these are from Japan, and it's very hard to know if we can generalize those results beyond Japan. And also, those studies use massive amounts of vitamin K, and there are risks with taking too much vitamin K, including clot risk. And so in our clinic, we really just focus on if you get it, if you eat a regular diet, we do not recommend additional vitamin K supplementation. If you have dietary restrictions, then it's important to see a dietitian and see if you need to take any extra. But in our clinic, we do not recommend additional supplemental vitamin K based on the literature.
Thank you. There's a question here too about someone who had a DEXA scan and they were classified as osteopenia, and wondering if there's things that one can do to prevent going from being osteopenic to osteoporosis. Dr. Kherani, I see you've unmuted. Would you like to speak to that?
Yeah, it's an important question that we review with patients regularly. And in reviewing that with your healthcare provider, hopefully they'll be able to explain not only what osteopenia means or low bone mass, as the term that we often will use now, but in the context of your health, your medical conditions and medications, and using that along with the fracture risk assessment tool that Dr. Yi showed during the presentation to be able to help with identifying what your overall risk might be predicted at over the next 10 years. And that will be what will help with being able to identify about what is your risk of a future fracture. Irregardless of that risk of a future fracture, those really important things of modifying risk factors that you have control over, looking at optimizing things that we can do for calcium intake through your diet, supplements if needed, and then vitamin D intake, as well as the areas of exercise that we talked about. Weight-bearing exercise, balance exercise, strengthening and bone building types of exercise can be really important to augment what we're doing. And then where medicines will fit in can be discussed depending on the nature and the type of risk that you might have as an individual. And I guess along with that, I think one of the questions that was popular was about what do we do for calcium intake in terms of from your diet if you're dairy intolerant. And so that is important. We know that milk serves as a really popular and a really easy way of being able to get calcium with 300 milligrams or so from a standard glass of milk. But there are other ways of being able to get calcium. And if you aren't getting enough calcium, then using supplementation would be appropriate that way. I often will refer patients to the Osteoporosis Canada website using the calcium calculator there, and that will allow you to be able to itemize foods that you can take that will be and be able to help you calculate how much calcium you're consuming.
Perfect. That was my next question, Dr. Kherani. So you must have read my mind and moved ahead to that question. And thank you for mentioning again about exercise. As a physical therapist, we know there's great evidence about the effectiveness of exercise and how it's the platform for us all to be not just for our bone health, but for our muscle health and for our heart health and for our lung health, etc. I note that there's a couple questions in the chat about questions related to, oh, well, what if I have a total knee replacement? Can I still do that exercise? Or you mentioned some specific exercises that have been shown. Sometimes patients, we're not sure if a particular exercise is a good exercise for us as an individual. If I might just take the opportunity to mention that a physical therapist is a great person to go and have that conversation with, who can do an assessment with you to see what exercises are appropriate for you or what ones need to change, you be modified in some way, or that you shouldn't be doing. So I would encourage people to, here in British Columbia, if you Google find a physio, you can get a list of physios that are where you are. And you can also put in a keyword to search by expertise. So you could put in osteoporosis and find out who has special training in osteoporosis. So just taking the opportunity there to speak about that.
It's
And it
so
takes,
important, Alison. I was going to add that the VIVA study for vertebral fracture has been looking at and continues to look at how our physical therapists can educate patients on reducing pain and improving mobility and function with the exercises that they learn through that study. And so those are things that we will continue to keep updated.
excellent. And I guess, I'm looking at the time because we want to save some time also to, after our thank yous, to share the video with everyone, the 6-minute video. But when we're talking about different people on the team that can help you with osteoporosis, there was a question about what is the role of the family doctor? And as a patient, who do you have this conversation with? Do you speak to your nurse practitioner about it? Do you speak to your family doctor about it? Do you speak to your rheumatologist about it? Do you speak to your physiotherapist about it? As we just said, who should we be having those conversations with?
I think that you can begin to have those conversations with any of your care providers, but starting those conversations is taking the first step. Having that conversation with your primary care provider, often that is a nurse practitioner or a family physician or a family doctor, will be a really important step in then trying to navigate where you go next, calculating and looking at risk, and seeing whether or not other tests need to be done or referrals to specialists can be a conversation that's had. Even speaking with your pharmacist can help, in addition to, as Alison said, your physical therapist. And remember that all of this begins not only as we get older, but even at a young age. So kids and teenagers, young adults can be working on leading a healthy life, being active in exercise, having a healthy diet. All of those things are really important to then their future bone health. And then keeping that in mind can be helpful so that as you get older and are able to then look after your health, you're asking the right questions to all of the people that are on your team.
Thank you. It sounds to me like you're speaking about the importance of our bone bank and making deposits earlier when
Yeah.
we're younger. I just want to take the opportunity now to thank the Arthritis Research Education Series sponsors for their support for this session. So AbbVie, AstraZeneca, Biocon Biologics, Celltrion, Organon, Pfizer Canada, Sandoz, UCBC Canada, and Fresenius Kabi. I really want to thank again our presenters, Dr. Kherani and Dr. Yi. I know how much work goes into preparing these sessions and preparing the slides and how much you deeply care about getting the right amount of information in the right way to people so that they can take it on to improve their health as much as feasible. I also want to mention that our patient partner for this episode, Mary Point, wasn't able to join today's webinar, but she has shared her experience, her personal journey with osteoporosis in the video that you're about to see. I also want to thank those in the background, those people that you don't see on screen who are responsible for putting this together, the people involved at Arthritis Research Canada in registration, video development, running the Zoom, etc. And for those that are watching us either live or viewing the recording, if you haven't had the opportunity to visit our website and check out the Arthritis Research Education Series, I encourage you to do so at arthritisresearch, all one word, .ca/learn. We have episodes on a variety of arthritis topics that are basis of the work that's done here at Arthritis Research Canada. We're going to be sending you a quick survey after the video, and we hope that you'll take a few minutes to complete it. Your feedback helps us to develop future episodes. And everyone who completes that survey by November the 30th will be entered into a draw to win a $25 Amazon gift card. We're now going to play the video for you. So thank you all for joining us.
Each while, hello, bonjour, asiamnasiaya. Asiamnasiaya antha Mary Point, Tinitzanacho Matquiam, E Tinitzanacho YVR, Iati Ktsamaltsam, Ami Tsepquatquilam. In the language of my ancestors, I said good day to friends and respected visitors. My name is Mary Point. I'm from Musqueam. I'm also from YVR. Today we're sitting in my office at the airport, which is located in the Musqueam village of Ktsamaltsam, once known as the Blueberry Forest, a place of abundance. So I'm mindful every day when I come to work that I'm walking and working where my ancestors once walked and lived and thrived until they were rudely asked to leave, but where many still rest. So I try to honor their time on this island in everything that we do. And the last words I said, all are welcome to enter this place. I found out recently in the last couple of years that I have osteoporosis, and I've been on a bit of a learning journey, and it's been a time of reflection. What led to my diagnosis was sort of a series of events over the last decade or so. I'm a very busy person. I do a lot of events. I used to work in my home community of Musqueam where we had 14 facilities, so I was always running between them. And I fell a number of times, and I just put it down to being in a rush and maybe some uneven ground. But I think when I broke my pelvis a couple of years ago in February, the ER doctor looked at my list of breakages and felt it was time for a checkup and to see if there might be a little something more going on.
Osteoporosis is a medical condition that leads to an increased risk of bone fracture. We tend to think of initially osteoporosis being a silent disease. Patients often don't know that they have osteoporosis, but with time, particularly when there is a fracture or a broken bone, then that makes an impact on an individual's function and their ability to care for themselves or their family. There are many different risk factors, and I usually group them into things that we can't change and things that we can. So as we get older, there's an increased risk of bone fracture or osteoporosis. Osteoporosis affects women more than men. And as we get older, both men and women can be affected. There are risk factors that we can change. And so some of those risk factors include our nutrition, activity, some habits that we might have. And so things like taking appropriate amounts of vitamin D, calcium, and also exercise that helps with strength training, balance, and weight-bearing exercise can be very helpful.
Well, I know here at the airport where I work, it's the biggest building in BC, 3.5 million square feet, and I cover most of it most days. So just being mindful about movement and unwinding so that I don't have any more trip and falls.
When I started in practice, it was clear that we needed to make an impact on osteoporosis, and I started by giving sessions of education and even collaborated with a colleague in Fraser Health, Dr. Sonia Singh. And then later I got involved with some of that research, working on understanding a fracture liaison service. A fracture liaison service is a program where patients who have come to the hospital with a fracture have been identified as having had that fracture and then followed up with, in a standardized way, identified that they have had a fracture, the diagnosis of osteoporosis, and then have had investigations, and then hopefully led to an initiation of treatment. There's always an opportunity to improve care and access to care. I'm hoping that with some of the research efforts that we're currently undertaking, that we'll hopefully be able to highlight areas where there are these challenges and gaps in care, to be able to bring attention to them, so that then what follows is improvement in that access to care.
Access to care for Indigenous peoples has always been a bit of a struggle. The more that we come together to share research, to participate in trials, that ensures us as Indigenous people maybe wider access to better care going forward.
Currently, the BC Coalition of Osteoporosis Physicians is working with a specific First Nations community to develop research initiatives within that community to further evaluate the access to osteoporosis care and look at actual interventions that could improve the identification, investigation, and initiation of treatment.
I think what most people should understand about osteoporosis is that in this day and age, you don't need to be fragile. There is help, there is medication, there is treatment, and it frees us up to be who we always were.